Good day, everyone. My name is C.V. Mamaril, and on behalf of the Systems for Action National Program Office here at the University of Kentucky, I'd like to welcome everyone to today's PHSR Research in Progress webinar, focusing on the cost, quality, and value of public health services. And we are excited to have with us our Washington-led Directive Consortium, who will be presenting on the inter-organizational collaboration in local public health systems, implications for costs, impact, and management capacity. As a reminder to everyone, you can download today's presentation and speaker bios from the resources box in the top right corner of the screen. I also encourage everyone who have questions, you can start even throughout the presentation, type your questions in the chat box that can be found in the lower right corner of the screen. So to give an overview of the flow for today's webinar, I will first introduce our presenters, who will then give their presentation. Afterwards, I will be introducing our commentator, who will then give her commentary. And then we give time for our presenters to respond to the commentary. And then we open the webinar to questions and discussion from the audience. So for those who are not familiar with DIRECTIVE, DIRECTIVE is short for Dissemination and Implementation Research to Improve Value. And there were 4 of these 24-month grant awards that were awarded to a consortia of 2 or more public health PBRNs in 2014. And these studies build on improved DAX measures and methods and examine the facilitators for implementation of evidence-based prevention programs, focusing on the resources and infrastructures and partnership and inter-organizational coordination. These studies assess the quality and costs of public health service delivery strategies and draws conclusions on comparative effectiveness and value. So today's Washington, Wisconsin, New York, and Oregon's directive study is the 4th in our series of directive study presentations. So with that, I'd like to introduce our presenters for today. Our first presenter is Dr. Justin Marlowe, who's an endowed professor of public finance and civic engagement and associate dean for executive education at the University of Washington Evans School of Public Finance, Policy and Governance. Justin teaches public financial management and budgeting and has published 3 books and more than 50 articles on a variety of topics in public financial management, including the municipal securities market, capital budgeting and finance, local fiscal policy, public pensions and legacy costs, financing public health systems, and public-private partnerships. Dr. Marlowe's research support include grants from the Robert Wood Johnson Foundation and the International City-County Management Association. Justin has served on expert advisory boards for King County, Washington, and the Washington State Auditor and the National Academies of Science, and currently serves on a task force convened by the Governmental Accounting Standards Board to review potential changes to state and local governments' financial reporting practices. Justin also routinely works as a consultant and expert witness for clients such as state and local governments and investment banks. He writes a regular column in Governing Magazine and is lead author of Governing's Popular Guide to Financial Literacy series for state and local elected officials. Our other presenter is Dr. Betty Bekemeier, who is the University of Washington School of Nursing Associate Professor and Director of the Northwest Center for Public Health Practices at the University of Washington School of Public Health. She is a nationally recognized public health systems and practice-based researcher focusing on structures and services of state and local health departments in relation to health outcomes and reducing disparities. Much of Betty's research and leadership in advancing public health systems has been conducted with state public health practice-based research networks and the National Network of Public Health PBRNs. He leads several PBRN-related research projects, in particular the Public Health Activities and Services Tracking, or FAST study. FAST is an ongoing multi-state PBRN study to develop the evidence regarding health outcomes associated with variation and change in local public health infrastructure and service delivery. So with that, I'd like to turn it over to you, Justin and Betty.
Well, thank you very much, CB. It's really a pleasure to join you, and thank you all for tuning in to hear us talk about what we've been doing with our directive grant. We have just a quick overview of our grant as it stands right now. As CB mentioned, this is part of the directive program, We've had some wonderful people working with us on this project, starting with, I want to first recognize in particular our staff here at the University of Washington. We've been assisted by Cherie Squires, who's a PhD candidate in the School of Nursing at the University of Washington, and also by Greg Whitman, who is the manager for the FAST project that CB just mentioned. We also have had, and you'll hear about this throughout the talk today, great help from a variety of practice partners across several states. In New York State, we've been fortunate to work with the State Department of Health, and in particular, Chris Malin, Isaac Michaels, and Sylvia Pirani. In Oregon, we've been working with their CLEO, their Coalition of Local Health Officials, and in particular, Kathleen Johnson and Morgan Cowling. Here in Washington, as has often been the case with PBRN work in Washington State, we've been fortunate to work with the State Department of Health, and in particular, Jennifer Tabaldi. And at the University of Wisconsin, who's bringing up the Wisconsin part of this project, we've been working with Susan Zahner and Teresa Watts. So it's a great coalition that spans 4 states, and we've been able to learn a lot about the nature of cross-jurisdictional sharing in lots of different settings as a result of having a really broad-based geographic approach to this subject. To give you a sense of what we're doing in this project, our overall research question is to get at what's really a very basic question, and that is, how does cross-jurisdictional sharing affect the volume, intensity, and unit costs of public health services? This is cross-jurisdictional sharing is certainly not a new thing. There's been lots of discussion about it, both in the academic literature and also in the popular press and in the professional literature in public health. And what we're trying to do in this study is really get down to the very simple question of when local health jurisdictions engage in cross-jurisdictional sharing, what does that mean for services? Does it make services more efficient? Does it make them, does it expand the volume and the reach? Does it maybe potentially help to address inequities in service delivery? All of those questions about the sort of impacts and outcomes associated with cross-jurisdictional sharing. We're starting from the place that a lot of the literature in this space starts with, and that is the assumption that sharing generally does lead to those outcomes, to better outcomes with respect to unit costs and efficiency and volume and reach. And we're also going from the assumption that more formalized sharing is more likely to produce those results. And we'll talk in a second about what we mean by formalized sharing. But there's a variety of different kinds of cross-jurisdictional sharing, and we're really focused on sharing that is driven by a memorandum of understanding or a contract or some sort of formal document that makes the nature of that sharing very formal. We're coming at this from a variety of empirical approaches. The first and most of what we'll talk about here today is a survey that we put in the field last summer that replicates some prior survey work that's really designed to get at the nature and the extent of cross-jurisdictional sharing. It's distributed to local health jurisdictions in 3 different states, and from that we're able to get a good sense of the landscape of sharing in lots of different areas under lots of different circumstances. Our next steps are then to combine those survey findings with the actual service delivery outcome measures, the improved measures, which many of you have probably heard about, and also combine those survey measures with some LHJ spending data that can help us to get some sense of those impacts on, again, things like efficiency, volume, and reach. A lot of our emphasis for that part of the analysis is specifically on communicable disease services, which are an area that tends to have some of the best available data to pull together all these different moving parts to be able to make that kind of a statement. We're also focused on some case studies, which we'll talk about here at the end. And those case studies, I think, are a really important contribution to better understand exactly why this is happening. It's one thing to show empirically that cross-jurisdictional sharing improves outcomes, makes services more efficient, improves volume, reach, but then there's the question of why exactly that happens. Is it the result of new capacity that cross-jurisdictional sharing can bring online? Is it the result of making better use of resources? You know, what exactly drives those effects? And that's what we're trying to get at in the case studies, which are an important third part of our analysis. Just to give you a sense of what we're finding so far, at this point we're finding that really 4 main points. The first is that in most cases, local health jurisdictions are using cross-jurisdictional sharing to improve or to bolster service delivery. We found some instances where local health jurisdictions are doing sharing as a way to bring online a service that they don't currently provide. or to bring online a service that they used to provide but can no longer provide. There's definitely some of that, but the vast majority of the sharing that we saw was local health jurisdictions saying that they wanted to be better at delivering services, either more cost-effective, better volume, better reach, whatever it might be. So as it sees cross-jurisdictional sharing as a way to improve service delivery, not necessarily as a substitute for service delivery. We're finding that sharing is most common in a couple key areas, things like emergency preparedness, communicable disease, maternal-child health, and epidemiology. That's consistent with some of the prior work in this space. We're also finding that small local health jurisdictions are more likely to engage in sharing, again, likely as a way to make better use of their limited resources. And the last piece, and what we're able to at this point provide a very kind of initial set of findings around, is that in fact sharing does seem to improve volume, reach, and efficiency for certain kinds of public health services. We have a very initial set of findings that we can show here at the end that speak to that finding. To be clear about some of the context here, cross-jurisdictional sharing is part of obviously a much larger conversation in public health and really in public administration and public management in general. When we use the word cross-jurisdictional sharing, it's often used alongside terms like interlocal collaboration, functional consolidation, and this is intense, formalized, often sharing of services and resources across local health jurisdictions. Most of the time, words like collaboration and functional consolidation are used as an alternative to more formal types of consolidation, annexation, regionalization, strategies where local jurisdictions don't necessarily keep their identity. They're brought into a larger political or a larger management structure in the form of a consolidation or an annexation or something like that. So there's this kind of general narrative that's out there that pits interlocal collaboration as an alternative to consolidation. And there's definitely support on both sides of this. Certainly, New York State has received a lot of attention as of late. Governor Cuomo there recently proposed a rather large initiative to try to reward jurisdictions that are able to find efficiency largely through consolidation by local governments finding new efficiencies by getting rid of duplicative units of government, and has put quite a bit of money on the table as an incentive to drive that kind of discussion in New York State. By contrast, in Oregon more recently, we've seen specifically in the public health space, again, some real active discussion about the potential for regionalization and the state government promoting regionalization, but as an alternative to that, of course, having a real active effort to try to understand where cross-jurisdictional sharing is happening and whether cross-jurisdictional sharing is an effective alternative to regionalization and consolidation. So there's definitely a lot of this conversation happening in the policy sphere. We do have some literature that speaks to this. There's a small but important literature that shows that, in fact, consolidation and regionalization can produce some significant efficiencies of the sort that are talked about among policymakers. And there's also been some work in the public health world looking specifically at cross-jurisdictional sharing, and shows that cross-jurisdictional sharing can have some of those same kinds of benefits. Most of the work has been on sort of a more limited basis, either a case-by-case basis or findings limited to a specific state or a specific type of local health jurisdiction. The real strength of what we're doing here is that we're taking a really broad base, looking at lots of different geographic areas, lots of different kinds of local health jurisdictions, lots of different kinds of services. The backbone of what we're doing is a survey that I mentioned, and just to give you a little bit of detail about how we went about our survey process. So we administered a really comprehensive survey to local health jurisdictions in 3 states, New York, Oregon, and Washington. And that was really put into the field last summer, wrapped up in August or so of 2015. And this was based largely on some prior work that was developed by our discussant for today, Kasuma Manmala, for some work that they had done in Wisconsin not that long ago. And as a part of what we're going to do in our overall analysis is to compare very directly the findings from our survey to the findings from their survey and treat it as one large survey administration effort that will cover a couple hundred local health jurisdictions as a result of that. The nice thing, our response rate was generally quite strong, and one of the nice things about this respondents that we were able to get was that it's a nice mix of both rural and urban jurisdictions. Several rural jurisdictions in places like eastern Washington and upstate New York and eastern Oregon, but also lots of important urban areas, New York City, Seattle, King County, Portland, Milwaukee, places like that really give us a nice blend. As I mentioned, the response rate was strong. We had lots of jurisdictions telling us that they had done various forms of cross-jurisdictional sharing. About 70% say that they're doing some kind of sharing, that they have at least one sharing arrangement currently in place. About 28% said that they're now sharing more than they did in the past 12 months. So there's definitely some momentum favoring doing more sharing than doing less. We also found that about half of the sharing arrangements that are currently in place are more informal. They're generally handshake agreements as opposed to formal memoranda of understanding or formal arrangements where there's a contract or some other legal document behind it. And one of the more sort of striking and interesting findings is that the majority of the sharing that we're able to document has come online since the Great Recession. About 85% of the cross-jurisdictional sharing arrangements that we documented have come about really since the 2008-2009. So the intense pressures that a lot of local health jurisdictions are under, shrinking revenue bases, expanding costs, it seems to have really been a big motivation, or at least a catalyst to get a lot of local health jurisdictions thinking about the potential impacts or the potential value of cross-jurisdictional sharing. The next couple slides here are designed to give you a sense of the kind of where sharing is happening, and we provided some summaries at a couple different levels here, and would be happy to follow up with anyone offline who has interest in seeing these data broken out in different ways. This first slide is getting at sharing broken out by state and also by program or capability area. The survey allowed us to get at sharing across a variety of different service delivery areas, things like emergency preparedness, communicable disease, maternal child health, but also across what we might call capabilities, right? And particularly in areas like communications, finance, purchasing, some of those both back office kinds of functions, but also those sort of capabilities that are really necessary to have a fully fleshed out public health program in a lot of the kinds of services that we're talking about here. So this chart breaks it up by state. New York is in red, Oregon is in blue, and Washington is in green. And along the x-axis there, the bottom axis, you see just the straight number of sharing arrangements that we saw across local health jurisdictions in each of these states. The reason this chart works is, if you recall from one of the previous slides here, we have roughly the same number of local health jurisdictions that responded to the survey in each of these different jurisdictions. We had 28 in New York, 30 in Oregon, and 25 in Washington, which, just to reiterate, was about a 65% response rate total. So we're looking at about the same number of local health jurisdictions in each of these states. And each of those dots then tells you the amount or the frequency with which that cross-jurisdictional sharing was happening in each of those different areas. So as mentioned, things like emergency preparedness are very common across all three states. Epidemiology, communicable disease, tend to see a similar pattern across all three of the states. And this is also roughly similar to what was observed in Wisconsin in some of their work. This is a breakout of where sharing is happening by population of local health jurisdictions, breaking it out into basically four different categories of local health jurisdictions, those that are sharing, I should say 5 different categories of local health jurisdictions, those that are serving populations of under 50,000, all the way up to those that are serving populations of greater than 500,000. And the general takeaway here is that, as mentioned, cross-jurisdictional sharing is much more popular for smaller jurisdictions. In the Oregon case, for example, if you look at the middle part of that chart, we see that there's a large number of jurisdictions that are sharing that happen to be in those 0 and 1 categories. That is to say, jurisdictions that are serving populations of 50,000, less than 50,000, or between 50,000 and 100,000. And a similar trend in Washington, and to a lesser degree, but still there, from New York as well. So again, sharing is much more common among smaller local health jurisdictions. This chart shows us the extent to which cross-jurisdictional sharing is being developed. The prior chart was about where cross-jurisdictional sharing is in place, where there are arrangements that have been developed. This tells us something about where sharing arrangements are in negotiation or are being developed. And again, we see a similar pattern here. Lots of action in emergency preparedness, things like chronic disease prevention, maternal-child health, so that the pattern of programs in development is very similar to those that are currently in place. It's also worth noting that some of those numbers are quite high. There's roughly, in some of these areas, you see 2, 3, 4 jurisdictions that are planning to add these as cross-jurisdictional sharing areas in the not-too-distant future. So the numbers that we showed for arrangements that are in place will definitely increase as a lot of these arrangements come online in the next several months. And finally, for the dot charts here, this is a chart that shows the underlying motivations for cross-jurisdictional sharing. Our survey allowed us to get at why it is that jurisdictions have decided to enter into a cross-jurisdictional sharing arrangement. A couple of important points at the outset before we even talk about what we found here. We allowed jurisdictions to give us multiple answers for this question. So essentially, it was a check all that apply structure for this question. So it's possible for jurisdictions to tell us that they are sharing for multiple reasons. And so what you see here is really just the most frequent responses. They're not necessarily the only reason why a jurisdiction would do sharing, but they're just the reasons that showed up most frequently. And there's kind of two important things that appear here. Number one, we see that provide better services and make better use of resources are the most common. And those are the most common across all the different kinds of programs and capabilities. Each colored dot represents a different program, service, or capability area. And then on the bottom there, we have the percentage. So this was the number of jurisdictions that identified that reason in that program or service area for entering into a sharing agreement. So for virtually all of the different service delivery capabilities and areas, we find that provide better services and make better use of resources was one of the main motivations. Things like save money, which previous work has shown is an important underlying motivation, are also there. There's between 25 and 50% of the jurisdictions said that was one of the reasons why they had entered into a sharing arrangement. So that's definitely there, and that's not necessarily mutually exclusive with make better use of resources as well. And as we'll talk about in a second, that's a relationship that we're trying to tease out a little bit more later on. Another key takeaway here is that there's what seemed to not have as much traction, or what reasons we found did not seem to be as compelling, and that was things like, again, providing new services, bringing new staff into the mix. This notion of building new capacity does not seem to be one of the main drivers across all the different areas of capabilities and services areas. So this was, we thought, an important finding that the cross-jurisdictional sharing helps you do what you're currently doing better, as opposed to helping you bring services or capabilities or capacity online. The survey gave us lots of space to talk about some of the more kind of qualitative perceptions, or to give respondents the sort of story behind why they entered into and why they think their arrangements are working. The vast majority, 90+% of the respondents said that their cross-jurisdictional sharing arrangements are effective. They said that they're effective because they help them do things like deliver services they otherwise couldn't deliver. But more importantly, areas like it improved our depth of knowledge, gave us capacity that we didn't have, so it can help them to deliver existing services more effectively or extend their existing capacity a little bit more. At the same time, and this is definitely something that deserves some follow-up, the vast majority of cross-jurisdictional sharing arrangements don't have any sort of formal evaluation mechanisms. There's not a contract, there's not a formal evaluation process or formal performance benchmarks. Most of the time when respondents said that they have an evaluation process, that evaluation process was something to the effect of, well, if the contract is renewed, then we know that it's going well, or if we get the grant, then we know that it's performing effectively, and we consider that an evaluation mechanism, which isn't necessarily a bad thing, but it's also not not as formal as we see in some other areas of public health, where the evaluation process is much more formalized. So it's definitely an area for future exploration. To what extent, when there is sharing, how and when does it work, and how do we evaluate whether or not it works? We can also, again, very briefly talk about some of our initial findings around the impact that cross-jurisdictional sharing has had on actual service delivery outcomes. And again, we do that by combining our data with the improved measure, the multi-network practice and outcome variation measures, a big part of which has been done here at the University of Washington in Betty Bekemeier's shop, my co-presenter here today. And what we're able to do is combine our survey findings with the improved measures in a couple areas, and in particular in the area of communicable disease. So in communicable disease, we have measures like childhood immunization rates, case volume in areas like sexually transmitted infections and tuberculosis, foodborne, waterborne diseases, and then we also have some staffing and resources measures as measures of capability in communicable disease areas. So we're in the process of trying to match and compare the patterns in these outcome measures on the basis of whether or not a jurisdiction has a sharing arrangement or not. This chart gives you a kind of an initial indication of what this analysis is going to look like. Here what we've done is created two very simple distributions. These are just smoothed, think of them as smooth histograms or smooth charts that show the distribution of jurisdictions. The blue line charts the distribution of childhood immunization completeness as a percentage for all of the jurisdictions that do not have a cross-jurisdictional sharing arrangement around communicable disease. The orange line shows that same distribution for jurisdictions that do have cross-jurisdictional sharing arrangements around communicable disease. And the punchline is very simple, and that is that there is a higher rate or a higher overall tendency toward childhood immunization completeness for jurisdictions that have cross-jurisdictional sharing. So we need to better build this out, definitely do some multivariate analysis to make sure to rule out any alternative explanations. But at a glance, this shows sort of the potential impact or the potential benefits of cross-jurisdictional sharing, at least in this case, showing that jurisdictions that share tend to have better childhood immunization completeness. So we want to do a variety of things to extend this research even further. Again, continue to try to look at the relationship between sharing and volume intensity of communicable disease services, similar to what I just showed. That'll go on throughout the rest of the spring. As mentioned, we're doing a lot of case studies at the moment to try to understand exactly why that's happening. If, for example, a local health jurisdiction was found to have a better childhood immunization rate because they were sharing, the question then becomes, what exactly is the underlying reason for that? Did that give them access to better staff, access to new resources, better communications capabilities, better coordination capabilities? What exactly explains that outcome? And we're doing that through our case studies, which I think will give us a real rich set of explanations to compare and contrast to a lot of the really good case study work that's been done so far in this space that shows some of the main outcomes that we care about. We're also looking specifically at unit costs. We were able to combine these findings with some of the spending data that we have in Washington State and in some other states to try to see if we can actually measure efficiencies in terms of unit costs. And that work is ongoing, and we hope to have something to share on that as well. We also wanted to briefly mention some of the other work that's being done in this space. The Center for Sharing Public Health Services has been doing this work for some time now, has an innovative program that they have now put in the field where essentially giving out grants to teams that are local health jurisdictions that are in the process of exploring or planning or putting cross-jurisdictional sharing arrangements in place. So really, again, going back to the point about evaluation and understanding the relationship between how sharing arrangements are developed and then whether they have their desired outcome, this is a really unique opportunity for local health jurisdictions that are interested in doing this to try to get some funding up front to help with the planning and the evaluation process. There's also been, also by the Center for Sharing Public Health Services, a variety of really good case studies that they were produced in concert with the International City County Management Association that illustrate a lot of the kinds of sharing dynamics that we're talking about here in a couple jurisdictions in Kentucky, Colorado, Connecticut. If you're at all interested in more detail about how these sharing arrangements are developed and how they have, and in some cases have unexpected effects, we'd encourage you to go to their website and take a look at those case studies. So with that, I'll give it back to B and the team, and as mentioned, my colleague Betty Bekemeier is here as well, and we look forward to conversation about our work. Thanks.
Thank you, Justin. Excellent presentation. And so we'd like to encourage everyone, if you have questions for Justin and Betty and folks up at Washington, you can type in your questions at the lower right corner side of the screen in the chat box. And we apologize that sometimes there's a lag in the technical aspect of it. So if we can't get to your questions at the end of the comments, we apologize, but we'll make sure to forward this to Justin and Betty. So with that, I'd like to introduce our commentator for today, who will be commenting on the presentation. We have with us Dr. Kusuma Madamala, who is an independent public health systems consultant with 18 years of experience in public health practice and research settings. She has also worked with the National Network of Public Health Institutes, the Association of State and Territorial Health Officials, the Institute for Wisconsin's Health, and she's also worked with the American Medical Association as a senior scientist, leading initiatives to bridge clinical and population health, and the Minnesota Department of Health and the University of Minnesota. Kusuma is an adjunct assistant professor and a member of the DRPH faculty at UIC School of Public Health and the Medical College of Wisconsin. Kusuma's areas of interest includes public health systems and services research with an emphasis on the performance and quality improvement activities of health departments. So with that, I'll turn it over to you, Kusuma.
Thank you, CB. And I want to say thank you to Dr. Marlowe and Dr. Bekemeier for asking me to provide a brief commentary on the value of this work for building the PHSS evidence base and provide a few implications for future research. As Dr. Marlowe indicated, the survey that was utilized in the work presented was developed in Wisconsin in 2012 as part of a Quick Strike grant to really explore the extent and nature of service sharing between local and tribal health departments in the state. And at that time, several years ago, we received extensive qualitative comments regarding the outcomes, perceived gains, and both how effectively and efficiently these shared services were provided. And what was needed in the next step was really to measure these perceived outcomes of service reach, volume, and the perceived cost savings that are resulting from service. The finding that was presented here, that 70% of respondents are reporting one or more shared service arrangements in these states, demonstrates that sharing services in local health departments is a fairly common practice, not only in Wisconsin, where our latest data shows 78% of local health departments are reporting sharing, but elsewhere. And they also have similar motivations for engagement among. In terms of evaluation, the contract renewal process is also less frequently cited on the Wisconsin written agreements study that's being led by Susan Zahner. So that correlates with that as well. I think it's exciting to combine this cross-jurisdictional service sharing data with the improved measures for communicable disease. I think the improved measures are the type of evidence we need, and this work is really beginning to contribute to our understanding of what effect these shared service arrangements may actually have on the community that they're serving. In thinking about some implications for future research, generally there seems to be more sharing in the programmatic areas, emergency preparedness, environmental health, MCH, than more organizational functions like communications and IT. And how are those motivations for entering those different types of agreements different, and what facilitates the sharing in organizational functions which can be more foundational to the agency? I think as the study explores the outcomes from service sharing with improved communicable disease measures, understanding what factors, if any, may facilitate the greatest gains in reach, volume, and savings of the shared service. And are those factors connected to any way to the practice-based success factors for a cross-jurisdictional sharing arrangement that's been presented by the Center for Sharing Public Health Services? Additionally, if outcome measures other than communicable disease are used, then comparing if certain program-specific shared service arrangements, for example, MCH versus environmental health, which yields us the most in return in terms of service reach, volume, and cost savings, as well as the nature of that sharing. For example, if we're sharing staff, is there minimal qualifications of that staff member that need to be met for that sharing to be successful? Lastly, I think there's a future opportunity to begin to develop various governance models or frameworks of service sharing between local health jurisdictions as well as with the state and non-traditional public health. Overall, I think what's coming up for the study is very exciting, and I'll be interested in learning more about the results obtained from examining the service volume analysis of. All of this combined will make an important contribution to our understanding of some opportunities for synergy across our delivery and financing system. So CB, I'll turn it back to you.
Thank you very much, Kasuma. So with that, we'd like to give an opportunity to Justin and Betty and the folks up at Washington, the Washington-led Directive Consortium, to respond to the comments or even add on to their presentation too as well.
Thanks, Kasuma. That was great. And you raised a lot of some of the interesting takeaways for us too, sort of where to go, where this could take us in the long run and areas to examine, et cetera. And I want to add that these improved measures, you know, some of you know that those of us with FAST in particular have really been beating this drum around standardized measures around public health services and activities, et cetera. So these are the improved measures that some of you are aware were developed through this six-state consortium led by Glenn Mays a few years ago, three years ago maybe now, or four. And then since then, we here at FAST have worked very heavily on these measures in terms of refining them further, et cetera. So they're a little different than the original measures that first pilot work done in the development of them and the collection of them. And then since we've gone through all those data, we've also then refined the measures a little bit further. So they're very similar. Some of them are slightly different, but more refined and therefore ideally even better data. So it sort of speaks to excitement we have too about the one piece of this is, you know, what you can start to do when everybody's pulling together exactly the same type of standardized data, and you can start to monitor the impact of some of these kinds of activities. And you also raised a real interesting point too, Kasuma. I like your thought about minimum qualifications of staff that might be shared and what the relevance that has for successful sharing, and how interesting it would be to really start to be able to tease out different kinds of arrangements around actual, you know, some of our workforce data and trying to pull those data together better too in the future. But anyway, those are just some thoughts and additions I wanted to add.
Thank you, Betty. So now we'll open the webinar to questions. So again, let me remind everyone, you can type in your questions in the lower right corner of the screen, and there is a delay. So if we don't get to your questions by the end of the webinar, we will make sure to forward these to Justin and Betty. So our first question is from Peggy, who asks, did those jurisdictions with better immunization rates specifically have CJS agreements related to communicable disease, or was it just those sharing any services?
Yeah, good question, says Justin. And yes, they did have those. The emphasis there was specifically on cross-jurisdictional sharing arrangements related to communicable disease. The specific focus of the arrangements within the context of communicable disease varies a bit. There are some that actually have arrangements specifically around immunization, and then others that have arrangements that are focused on other areas of communicable disease. One of the things that we really want to get at is whether there's potential spillover benefits or kind of indirect benefits of having a cross-jurisdictional sharing arrangement in one area that then produces benefits or produces better outcomes in other related areas, perhaps because it frees up capacity, perhaps because it allows you to use resources differently, whatever it might be. But the simple answer to that question is yes. We're focused for that part of the analysis just on jurisdictions that say they have cross-jurisdictional sharing arrangement in that specific service area.
Thanks, Justin. Another question is from Pat. Is there any information from policymakers with regards to the response to these cross-jurisdictional sharing in public health? And I'd probably just add on to that. What are some of the potential implications you see for policy in terms of, given that your results sort of suggest that a lot of these agreements are not formal and they involve the smaller health departments, and the motivation is not really cost saving, but more, I guess, for effectiveness and efficiency in providing, improving the quality of the services. So I guess I put in all those general questions to you, Justin and Betty, with regards to Pat's question.
Sure. Yeah, that's a great question. We don't have data at the moment specifically on policymakers' responses to cross-jurisdictional sharing. But I would say two things in response to that. Number one, in the case studies that I mentioned, our interview protocol for the case studies gets directly at that. We're asking local health jurisdiction officials who have been involved in either developing or implementing cross-jurisdictional sharing arrangements, to what extent has support or encouragement or even discouragement from elected officials and other policymakers been a factor driving how the sharing arrangement unfolds over time. So that's obviously a crucial piece of this, the kind of governance piece of it, and we want to try to capture that to the extent that we can. We do have, the second thing I'll say is that we do have in our survey some questions about, and this is the same as was the case in the Wisconsin and some of the other surveys, some questions about the role that elected officials played in developing or generating interest in cross-jurisdictional sharing in the first place. So we are able to speak maybe not to policymakers' response, but policymakers' general attitudes or general support for sharing, and the importance of that as both a success factor and as a factor in driving the development of cross-jurisdictional sharing in the first place. So we really do hope to be able to make a statement once this is all done on the many different ways that policymakers connect with and interface the process of building and implementing cross-jurisdictional sharing arrangements.
But Justin, but we won't have collected data from elected officials directly. It's all through our public health folks.
Yeah, that's right. We've had in the process of developing our cases, we've actually had elected officials who have said that they want to talk to us, who have said that they want to be interviewed and they want to share their views, and we're happy to get those perspectives where we can. But you're absolutely right. The research methodology is focused on local public health staff as the main actors, and to the extent that we can talk about elected officials' attitudes, it's going to be from the perspective of local health officials.
And that, my understanding, is a difference between our work and and what, for example, is being done at the Center for Public Health Sharing. I think there has been specific engagement around and collection of information from elected officials themselves, but that's not been our approach here, and could be considered a limitation of this study, but those are the parameters we put around.
Sure.
I think we have one more question from the chat box from Jason. Was the direction of the relationship examined, i.e. the services provided versus received, as it related to the LHD? Are there patronage systems essentially being developed as a result of the availability of resources in some LHDs versus others?
Yeah, good question. I guess I'm not quite clear on to the direction of the relationship examined, services provided versus received. I mean, just to clarify, so our research methodology allows us to get at sharing arrangements from both the perspective of local health jurisdictions who are delivering services on behalf of another jurisdiction, and those that are receiving services delivered by another jurisdiction as part of a cross-jurisdictional sharing arrangement. So if I'm understanding that question correctly, we're looking at both. We're looking at sharing arrangements from both directions. And when we identify in our data that there is a sharing arrangement, it's because both sides of the sharing arrangement have identified that there's a sharing arrangement in place. And some of those, as I think this question kind of implies, some of those are in fact just one jurisdiction is going to deliver a service to another jurisdiction in exchange for some fixed payment over a certain period of time, or in exchange for another service over some period of time. And it's important to be able to identify that as something very different from both jurisdictions collectively are going to go out and hire an epidemiologist, or both jurisdictions collectively are going to go out and build a new a new testing facility or something like that, as a very different kind of sharing. Both of those are sharing, and we're able to differentiate the different sort of flavors of sharing within that. With respect to patronage systems, that's a really good question. You know, we're not we're only able to sort of get at the questions of efficiency and necessity at a kind of surface level, at least at this stage in the game. So I would hold off on making any kind of assessment of that at this stage in the game. But absolutely, the question of if and when and how resources are being deployed efficiently and effectively by whomever's definition, that's definitely a part of what we're going to try to do in this research over time.
Thank you, Justin. And I think, again, we remind everyone, if you have questions, you can direct them directly to Justin and Betty. And it's going to be really exciting to see, Justin and Betty, how, you know, those questions about cost savings, efficiency, and also the effect of these cross-jurisdictional sharing services on outcomes as you collect that data and analyze that data later this year. That's going to be something to look forward to. So with that, we'd like to thank you again, Justin and Betty, and the Washington, Wisconsin, New York, Oregon Directive Consortium for your wonderful, excellent presentation today. And we'd just like to remind, we'd also like to thank Kusuma also for her time in providing comments. And we'd like to remind everyone that today's presentation and also past webinar presentations are available for download from our archive and our website. And we'd also like to welcome you, invite you to our upcoming webinars too as well, with the next one on March 16. So with that, we'd like to again thank our presenters and our commentators, and we'd like to thank you also for joining us for today's webinar. And we'll be able to give you back more than 10 minutes of your time today, and we thank you for joining us today. So with that, good day, and take care.